Okay, I think Tom Farden, who usually chairs this, is on holiday, so I will just set off without a chair. So my name's Katie Hands. I am one of the consultant haematologists, and I have responsibility for blood transfusion, the blood transfusion service in 9 Wells. What I'm going to speak about today is sort of generally about the management of massive haemorrhage. And then Eleanor Hazra, who is one of the transfusion practitioners in Tayside, is going to present about the new Massive Haemorrhage Policy, which is due to go live at the beginning of May. So it's great to see so many of you here today to hear about that, so you'll all be very well versed in it before you need to use it at the beginning of May. Okay. So, thought I'd start off by trying to set the scene about how much, what amount of bleeding we're actually talking about when we talk about massive haemorrhage. Now, as part of the setup of this new policy, we did an audit of 6 months' worth of massive transfusions in 9 Wells and found that there were 58 episodes in 6 months. So that's about 2 a week. And if you look at the components that these patients have transfused, on average they get a total of 10 components, and that's made up of 5 units of red cells, 4 plasma and 1 platelet. So that's the commonest type of massive transfusion that takes place in 9 Wells. But if you look at the extremes, there are occasional patients, maybe a couple a year, who get transfused huge numbers of blood components. And I've given an example here of a patient who ended up getting a total of 56 blood components over a period of about 2.5 hours. And that case illustrates just how high tempo these situations can be and how challenging they can be to manage, both for the clinicians looking after the patient as well as the blood bank who are working hard to provide the components that you need in a timely fashion. And there are all sorts of challenges, even simple things like keeping track of the patient. If you think the patient's coming in through the door of the emergency department, being transferred to CT potentially, then maybe to interventional radiology and on to theatre, blood bank need to be kept informed of where the patient is at all times so that they can get the components that you've requested to the patient. And if we look at where in 9 Wells these massive haemorrhages are taking place, broadly speaking, they're where you might expect. So they're happening in theatre, they're happening in the emergency department, surgical high dependency unit and labour ward. And it's very important that staff working in these areas where they're going to see lots of patients suffering massive haemorrhage are trained in identifying it early and activating the appropriate protocols. If we look at cases which happened in medicine, most of these will happen in the acute medical unit or in medical high dependency, where staff are likely to be relatively experienced at dealing with them. But there are odd cases which happen in other parts of the medical floor, and it's these low-use areas who are going to benefit at least as much from clear protocol-driven guidance to help them manage these patients that are having major haemorrhage. So what should we be looking out for in order to identify massive haemorrhage? Well, there are various definitions around, and some of them are more useful than others. The ones in the blue boxes there are based on either the volume or the rate of blood loss. And by definition, these are retrospective. If you wait 24 hours to check whether your patient's bled blood volume, your patient's going to be dead. So it's far more useful to use definitions which use the clinical situation. So these are shown in the red boxes. So this is bleeding which has led to shock, or bleeding which has prompted the use of emergency O-negative blood. An early recognition of massive haemorrhage and taking appropriate action is vitally important because these patients bleed to death quickly. Trials studying massive haemorrhage in the trauma setting consistently show that patients exsanguinate in about 2.5 hours from the time of injury. So it's really important that we're getting the appropriate transfusion support into these patients as quickly as possible. Recognition of a cluster of cases where delayed transfusion had led to patient death prompted the National Patient Safety Agency in 2010 to recommend that all hospitals should have clear protocols in place to facilitate the provision of blood in an emergency. And more recent data confirms that there is still significant morbidity and mortality related to delayed transfusion happening in hospitals in the UK. The Serious Hazards of Transfusion, or SHOT, is a haemovigilance organisation which reports annually on adverse events related to transfusion. And the most recently published report in 2015 highlighted 94 cases where delay in transfusion led to patient harm and 6 cases where patients died. And in most cases where these delays resulted in death, poor communication between the clinicians and the blood bank were highlighted in the root cause. And these cases are things that you can see happening in 9 Wells. So things like 2 patients in consecutive operating theatres with the same first name. The major hemorrhage protocol is activated for the incorrect patient, and that's not noted until blood arrives in the theatre and is labelled up for the wrong patient. Therefore, that incurs a delay while appropriate blood is requested for the right patient. Another case which the SHOT report highlighted was a discrepancy in a spelling of a patient's name, which again wasn't noted until blood had arrived at the patient. And there was actually a very similar case that happened in 9 Wells recently, where this discrepancy wasn't identified until the time the blood was being transfused. So protocols like the one we've been developing here for use in 9 Wells aim to streamline communication and minimise any delays in the provision of appropriate blood products. So as with any critically unwell patient, the initial assessment should follow the ABCDE approach, and then the management of massive haemorrhage really has 2 arms. The supportive treatment, so that's blood component transfusion, and that's what this talk and our policy focuses on, but also, and equally as important, is the definitive management of haemorrhage, so getting somebody organised to stop the bleeding, because blood transfusion alone is not going to achieve haemostasis. So what I'll try and do over the next little while is discuss the evidence that guides us in the management of massive haemorrage and highlight areas for which that evidence base is incomplete. And one of the things that we really do need to acknowledge is that for much of the guidance available, it is for guidance for the management of massive haemorrhage associated with trauma. And this is often then extrapolated to the management of major haemorrhage of other causes. So it's not all clear-cut. So if we go back to basics, a whole blood donation can be split into 3 components. Red cells, which you transfuse to improve the oxygen carrying capacity of blood. Plasma, which is a source of coagulation factors and is frozen soon after donation and stored frozen as fresh frozen plasma. FFP can be further processed into cryoprecipitate, which is a source of fibrinogen. And a usual adult dose of cryoprecipitate would include cryo made up from donations from 10 donors. Platelets are taken from 4 donations and pooled to make an adult treatment dose. And in an emergency, the blood bank will aim to prepare these components as quickly as possible. Now, if blood's required immediately, there are O-negative blood stocks in various locations in the hospital, the blood bank fridge, the theatre fridge, and the emergency department fridges, and these can be used if required. But you must remember to let blood bank know that you've taken them so that they can be replaced quickly for other patients. Depending on the situation, the provision of emergency blood may or may not require actual wet cross-match work in the lab. If a patient has a valid group and screen sample in the lab and various other criteria are met, blood can be issued by electronic cross-match, which means that blood can be fully cross-matched blood can be available within 10 or 15 minutes. Now, most hospitals actually issue the majority of their blood by electronic issue these days, and it relies on the fact that if the patient's ABO and D group have been reliably established by the analyser, and those results have been transferred automatically from the analyser into the computer system, and that a sensitive antibody screen has been performed and is negative on a historic and current occasion, the possibility of issuing incompatible blood is negligible. So as I say, for many patients who are having operations, who've had group and screen samples taken before their operation, we can actually issue fully cross-matched blood very quickly for these patients. If a patient starts to bleed who doesn't have a valid sample in the lab, or for example somebody who's been admitted via the emergency department, it will take approximately 15 minutes for group-specific blood to be issued from the lab, and that's having had a biomedical scientist determine the patient's blood group there and then. If a full antibody screen is performed and go on to cross-match blood, it will take up to an hour. So it's very important that in communication with the blood bank you let them know how urgent the need for blood is. FFP remains frozen until it's requested, and it takes about 40 minutes to thaw, so there's an inherent delay there between the request for the component and it being ready to be issued, so it usually will take about an hour from the time of request. Platelets are kept as stock in 9 wells and then can be issued on request. If they're required in Perth, they're sent through from 9 wells, so again there'll be a bit of a delay waiting for them to arrive. But the number of transfusions of platelets in Perth isn't sufficient to warrant keeping a stock there all the time. Cryoprecipitate that I mentioned earlier isn't usually used in the initial resuscitation phases, but should be given if the measured fibrinogen is below 1.5 grams per litre. And again, it's stored frozen and will need thawed before issue. So next, if we try and think about how best to use these components, historically the approach was really kind of a reactive approach where you would start IV fluids and then move on to red cells, and then when blood results came back demonstrating the patient to have a coagulopathy, you would then move on to transfusion of FFP and platelets. So almost sort of chasing the coagulopathy, if you like, trying to catch up and correct it. Now, in the late 1990s, data from the military and battlefield resuscitation using what was referred to as balanced resuscitation, so using a combination of components to try and mimic the composition of whole blood, appeared to be superior to this more reactive approach that had been used. And around this time, it became clear that the coagulopathy seen in trauma patients wasn't the late event that it had been assumed to be, that actually about a third of patients arriving at hospital were coagulopathic at presentation. So actually, further studies have gone on to demonstrate the benefit of using this early, more aggressive transfusional approach in the resuscitation of trauma patients, and this has been extrapolated into the management of massive haemorrhage for other causes, where unfortunately the evidence base is lacking. So the upside of this more aggressive transfusion approach is obviously the aiming that you're going to have better outcomes, that your patients are going to do better, be less coagulopathic, stop bleeding more quickly, and so on. But the downsides are the risks of overtransfusion and the risks of extra donor exposures and so on. Now, guidance suggests that one should aim to transfuse at least 2 units of red cells to 1 unit of FFP in the initial resuscitation phase, and then when blood results are available, use components to try and maintain a haemoglobin of between 70 and 90, a coagulation screen as close to normal as possible, and platelets above 50. And in trauma, it's recommended that that ratio is closer to 1:1, which I'll mention a wee bit more about now. So as I've mentioned, the area with most in the way of evidence in massive haemorrhage is in the context of trauma. Patients die quickly of exsanguination in trauma and may have an acute coagulopathy by the time they arrive at hospital. And this coagulopathy is due in part to hyperfibrinolysis, which prompted the CRASH-2 study, which examined the effects of tranexamic acid, which is an antifibrinolytic drug, on mortality for trauma patients. And 20,000 patients were randomised into this trial, and it was found that this drug reduced mortality in trauma patients when it was given within 3 hours of the initial injury, and reduced bleeding deaths by around a third. So tranexamic acid is now standard as part of the management of patients with major trauma, and in fact is being rolled out to be carried by the ambulance service in Scotland so that it can be given as close to the time of injury as possible. The proper study compared the effects of this 2:1 ratio of red cells in FFP to a 1:1 ratio, and demonstrated a decreased exsanguination in patients who received the 1:1 ratio. And this target should therefore be your aim in resuscitation of trauma patients. Now, to help this, there is a Code Red policy, which is in operation here in Nine Wells and in emergency departments elsewhere in Scotland. And what that allows is the trauma team, so consultant emergency medicine physicians who are out pre-hospitally treating trauma patients, to phone into the emergency department and activate the Code Red policy, which then alerts Blood Bank to start preparing blood components for these patients before they've even reached the emergency department. And what this does is helps to circumvent the inherent delay that's present in the need to, the wait that we have for thawing plasma. So this has reduced the time that patients with trauma need to wait for blood component support when they arrive in the ED. And it's also suggested that platelets ought to be given early to trauma patients. In obstetric hemorrhage, the initial stages of management should be as for the management of massive hemorrhage of other causes, doing the initial assessment, activation of the Massive Haemorrhage Policy, and then transfusion of components in these balanced ratios that I mentioned before. There are a couple of specifics, though, that are recommended for obstetric hemorrhage. Studies have demonstrated that low fibrinogen levels in women who are having postpartum hemorrhage are a predictor of the severity of the hemorrhage. Now, fibrinogen levels increase in pregnancy to levels of sort of between 4 and 6 grams per litre at the time of delivery. So if you measure a fibrinogen in a woman having a postpartum hemorrhage and it's somewhere even within the normal range, that may actually be low in the context of pregnancy, and therefore you should consider using cryoprecipitate to replace fibrinogen if the fibrinogen level is less than 2. So using it sooner than you would perhaps in major hemorrhage of other causes. There's also some preliminary evidence to suggest that tranexamic acid may help reduce blood loss in postpartum hemorrhage. And certainly we're waiting for the results of the Women study, which has been performed worldwide, where 20,000 women with postpartum hemorrhage have been randomised to receive tranexamic acid or not. And the results of that are due later this year. And that will obviously be of relevance to women everywhere, but perhaps particularly in the developing world where donor blood is unavailable. If this simple intervention can be performed, which will reduce blood loss for these women, that may have really significant public health effects worldwide. And at the moment, I think it would be reasonable to use tranexamic acid for women with postpartum hemorrhage, and that's certainly in keeping with the RCOG Green Top guidance that was published last year. For patients on oral anticoagulants, so we're fairly familiar with reversing warfarin. We use Beriplex, which is a 4-factor prothrombin complex concentrate, the dose of which is dependent on the patient's INR and the patient's weight, and that is issued from Blood Bank. And these patients should also be given vitamin K. For the novel or newer anticoagulants, things are a bit more tricky. For dabigatran, there is a licensed antidote, which we hold here in Nine Wells, but there aren't huge numbers of patients in Tayside on dabigatran, so we've not had cause to use that much. For rivaroxaban and apixaban, which are the drugs which are commonly used in Tayside, there isn't currently a licensed antidote, although there is likely to be later this year. So at the moment, the advice would be to stop the drug, to contact the haematologist, who would consider using Beriplex, so the prothrombin complex concentrate, to help reverse the effects. Other things to think of during the management of massive haemorrhage are making sure that you take serial blood samples. So if bleeding is ongoing and transfusion is ongoing, you probably want to be repeating bloods every 30 to 60 minutes to see, are you doing what you hope you're doing with the components that you've been transfusing. You need to keep an eye out for hypocalcemia, particularly if patients are transfused large amounts of plasma products, because the citrate anticoagulant in the components can lead to hypocalcemia. And also there may be large amounts of extracellular potassium accumulating in red cell components. So again, if a patient's having a massive transfusion, it may well be that they become hyperkalemic, so it's important to keep an eye on that. The blood components that you'll receive from blood bank are cold, so red cells are stored 4 degrees, plasma will still be cold after it's been thawed, so it's important to try and use a blood warmer where possible to avoid your patient becoming hypothermic, which can exacerbate any coagulopathy. And also, it may be an option if the bleed has happened in theatre to use cell salvage, and I know that that would be relatively common practice in obstetrics or vascular surgery, for example. And after bleeding is controlled, it's very important to think about thromboprophylaxis for these patients. So we know that trauma patients, obstetric patients, are going to be at high risk of thrombosis anyway, and particularly after the massive activation of coagulation that goes on during the body's response to massive hemorrhage. So once the bleeding's controlled, it's important to think about thromboprophylaxis as soon as is deemed safe. Just a couple of words about stopping the bleeding. It's not really my field of expertise, but what we would suggest is that you need to get senior help early and think about who is going to be stopping the bleeding and get in touch with them early so that your blood component support isn't going to have to support your patient for too long, basically. So that may be an endoscopist, it may be a surgeon, it may be an interventional radiologist, but it's just making sure that that thought process is somewhere near the beginning of your management as well. So I've presented some of the evidence that there is for managing massive hemorrhage, and as I say, most of it comes from the management of massive hemorrhage related to trauma. So I think there are lots of ongoing questions about whether we're doing exactly the right thing in the management of non-trauma associated massive hemorrhage. And I hope that there will be further studies that help clarify that over the next while. I think some questions which are in the process of being answered are the ones about tranexamic acid. As I said, the women's study is due to report this year to tell us about the use of tranexamic acid in postpartum hemorrhage. There's a study called HALT IT looking at the use of tranexamic acid in upper GI hemorrhage. We'll see what they show, and it'll be interesting to see if the same benefits are seen for all groups of patients. But certainly at the moment it would seem from the studies that there isn't a huge risk of harm to patients by using tranexamic acid in the massive hemorrhage setting, so it's probably something that would be reasonable to consider in most cases. As I said, the interest in the acute coagulopathy of trauma and this sort of hyperfibrinolytic state has prompted studies looking at the use of fibrinogen concentrate early in the management of trauma hemorrhage. Now, fibrinogen concentrate isn't licensed for use in this way. It's only licensed for inherited dysfibrinogenemias. So at the moment, any use of that would really be within the context of a clinical trial, but I think it would be interesting to see what those studies show. And the last thing which there is ongoing interest in is whether point-of-care coagulation testing is going to be a helpful thing to be doing for patients having massive hemorrhage. And these are the tests that look more globally at blood coagulation, so things like thromboelastography or rotational thromboelastography, for which there's evidence for using them as part of protocols in cardiac surgery, but at the moment there's no evidence for their use in other areas, for example in hemorrhage, but there's one currently being trialled in the emergency department of the Royal Infirmary in Edinburgh to see whether it's helpful, so we'll see what comes from that. Okay, so I think that's a quick whiz through the management of massive hemorrhage, and now I'll hand over to Eleanor, who is our transfusion practitioner, who's going to tell us a bit about the implementation of the new Massive Haemorrhage Policy in 9 Wales. Thank you.
Over the next 15 minutes, I'm just going to give you the basic highlights of the new Massive Haemorrhage Policy, which has been ratified. It's about to be ratified. Today. It's going to be ratified today. We'll keep my fingers crossed. Aims of today's talk, or what I hope that you will understand by the end of this 15 minutes, is why we've changed the massive hemorrhage arrangements, where you can find the policy and how to activate the policy and who you need to contact if you require any advice. The aim of the policy is to facilitate appropriate transfusion components effectively, efficiently and most importantly in a timely fashion. And this can be applied to any patient having a massive hemorrhage, whether they're in 9 wells or PRI. Community hospitals have their own different policies, and if they had somebody having a massive hemorrhage, the chances are that patient should be transferred back to here, or if PRI is closer to PRI. So, the background. This is what the current policy looks like that's currently out there. It was devised in 2013. It hasn't actually been updated in any fashion since then, so we're now in 2017. 4 years have passed. There has been a lot of work done in NHS Tayside. I have to say that Dr Sam Rawlinson was very forward in pushing through the massive hemorrhage policy previously, and if he was still with us today, he would be actively pushing this forward, very much so. The project came about, we wanted to look at the guidance that we had. We wanted to look at the national guidance. As Katie alluded to, the British Society for Haematology in 2015 were reviewing their massive hemorrhage guidelines, and we just wanted to see, did we actually match up with the guidelines? Was our policy fit for purpose? As Katie also previously mentioned in her first talk, any delay in transfusion can contribute to patients' death. So we just wanted to make sure, are our policies ensuring that blood components are delivered rapidly and appropriately to support these patients? So we performed a gap analysis, we had a look, we looked at other national guidance, we looked at Tayside's Guide to Massive Transfusion just to see, was it fit for purpose? The answer was, well, not particularly. In the short answer, it didn't meet the vast majority of the standards set out by the British Society for Haematology guidance. Notably, we didn't have a dedicated phone line to the blood bank for use in emergencies, which meant that the phone line could be tangled up by any ordinary day-to-day request while somebody was having a massive hemorrhage and they were requiring to get through to the laboratory at the same time. I have to say that that has never really been highlighted as a problem in 9 wells, but the national guidance said we needed to have a dedicated phone line. We also noted that we did actually have various guidelines across NHS Tayside. Kindly, our colleagues in AMU and paediatrics had taken national guidance and the guidance that we had and devised their own policies. Unfortunately, possibly on our part, we hadn't updated them or given them the advice that they required, so the policies were all mismatching, to be polite about it. So what we therefore decided that we would have a quick review and have a look at what we were going to do with a view to improving our policy. As Katie said, we did do a quick local audit. There were 58 episodes, roughly about 2 episodes per week. It did confirm that the initial transfusion support that we were supplying of 4 red cells, 4 FFP and 1 platelet were actually quite appropriate for our patients, and we would continue with that when we introduced our new policy. But it wasn't just about the blood components. We wanted to know about getting it right. What else could we actually do? We'd covered the blood components. We felt that that was appropriately going to be continuing what we were doing already. But what we wanted to do was, how can this policy ensure that you are getting the appropriate blood components rapidly? Well, it was all about communication. The use of easy-to-use flowcharts, which we've devised and which I will come to mention further in the talk. The importance of standing down the massive haemorrhage response. It was all fine that everybody would activate the massive haemorrhage response, the lab would be involved, we would know would be issuing blood components, but we never received the phone call at the back of that to say that, i.e. patient survived, hemorrhage has been stemmed, or patient has died. That always seemed to come a little bit further down the line, which led to us potentially wasting red cells, FFP and platelets. So we need to know when has it been stood down, and what's actually happening. If you have any components that are still in bags, still in the red transport boxes, we need to get them back as soon as possible. We appreciate that you're dealing with a major emergency situation, but these blood components, it's quite urgent that we get them back. So communication is the big thing for us. Having a team lead during the major hemorrhage, that to us we feel is one of the most major important things. Sometimes when we have a major hemorrhage, we can have 4 or 5 different people in the same department phoning us to tell us about a major hemorrhage situation. If the laboratory staff are there at 10 o'clock at night, there is one of them, but there might be 4 or 5 of you all phoning about the same patient. They can't be issuing blood components if they're answering the telephone to you. So we need to have one person who's in charge in this major hemorrhage situation, who is the person that communicates with the laboratory. They're the ones that know what's going on, they know what components are coming, and they know which components have been requested. And that was one of the things that we felt would be very beneficial. One of the things that we didn't do was actually to review our activations of major hemorrhage policy. We have now asked the Datex team here in NHS Tayside, and they have built in a special forum for reporting of major hemorrhages. If you go into Datex, if you choose to report blood transfusion incident, it will then show up with a different page for major hemorrhage activations. Why do we want to do this? Because we want to learn lessons from each major hemorrhage. Is there anything we can do quicker? Was there something that was really, really well done? We really need to know that. It's all about continually improving how we deliver blood components to you and ensuring that our patients are safe. So, when will this all happen? Well, the 1st of May 2017. We had hoped that the policy would have been ratified about 3 weeks ago, but unfortunately the committee wasn't quorate, so they couldn't ratify anything. So today, keep our fingers crossed, that that's what's going to happen. How to activate the policy? What do we require you to do? Well, what we require you to do initially is call 2222, state that it's a massive hemorrhage and the ward or clinical area that you're in. You don't need to give any further information to the switchboard at that time. That's all you have to say. Massive hemorrhage, ward X, and you put the phone down. What this actually does, it doesn't alert a cardiac arrest team, it doesn't alert a whole load of folk that are going to arrive in your department. What it does is the switchboard will then put out an alert to the blood transfusion blood bank so that they know to expect a phone call is going to be coming through. It also will trigger off various pagers across the hospital, especially at night time. The likes of the hospital at night team, they might not be coming along to your department, but it's so that these people are aware that a major hemorrhage is going on, so that if they're requiring porters for other things or there's another major incident happening, they need to know exactly what's going on. Once you've put the phone down for your 2222 call, if you're in 9 Wells, you will then phone 33394, it'll put you through to the blood bank. If you're in PRI, there's another number, you would contact the PRI laboratory. And again, you will state massive hemorrhage, ward X. At this point, the BMSs, they will have their little flowchart beside the telephone that will advise and they will ask questions. What's the patient's name? What's the CHI number? Where are you? Who are you? Who's in charge? What components? And they will just go through everything that you need to know. One person communication lead should handle all calls. It just makes it easier so that one person knows exactly what's going on. They will then prepare 4 red cells, 4 FFP and a platelet for you, and that is what will be issued. FFP, as Katie has said, it does take up to 40 minutes to thaw currently, so you will be issued with the red cells and the platelets first. At this point, if you have used any of the emergency O negatives, you will need to advise the laboratory because they will have to replace them. We need to know that quite quickly. We do have an S-bar. It was devised, I actually see one of the people that devised it sitting at the back of the room, way back in about 2014. It was devised for maternity services, but we just felt that it was actually a very good thing to have. It will be on the arrest trolleys, it will be in all the clinical areas, and again, it just goes through what information does the laboratory require from you? You know, is the patient shocked? Are they stable? When would you like the blood? This is what we're going to issue. Where the emergency O-neg blood is. If you're in Nine Wells, there's emergency blood in the East Block main theatre. There's blood in the A&E fridge. There's also the trauma box in the A&E fridge. And there's 2 units in the blood transfusion lab. If you're at PRI, they have 2 units of emergency blood within the main theatre. Sorry. This is what the flowcharts look like. The flowcharts will be available, as I said, along with the S-bar. They will be laminated. They will be on all the cardiac arrest trolleys. They will also be in all the clinical areas. If you're in any of your departments and you have a rough idea how many that you might need, please just contact Katie or myself and advise us, because we will get them laminated and you will get them. It goes through from start to finish what you need to do, who do you call, who do you then summon. As Katie said, okay, you've contacted the transfusion laboratory, but there might be other specialties that you require. Do you need a surgeon and somebody from endoscopy? But it will be up to you to contact these people. As we have noted, major haemorrhages, they have a tendency to occur in labour suite, theatre areas. You already have a plethora of fully competent, trained anaesthetists, surgeons. They're all there anyway. But what about if a major haemorrhage occurs in an area where they don't have access to all of these things? So they needed to know exactly what to do. And it just goes through the resuscitation, what components, what to do. And most importantly, at the bottom, communication lead to notify to stand down. You will then be asked to complete a massive haemorrhage activation record pro forma. And then that will be documented on Datex. For PRI, they have their own flowchart. It's just got a different phone number on it, but with the same information. And we also have devised one with the help of our paediatric colleagues for paediatric massive haemorrhages. And as I say, these will all be available laminated for use in your clinical area. Where to find the policy? Well, as I've said, the S-bars and the flowcharts will be on the arrest trolleys. The policy will be available on StaffNet. Under clinical policies, it will also be under the blood transfusion section and the deteriorating patient section. If you require further support, you can contact myself or my colleague Suzanne at PRI, any of the haematology on-call registrars, and Katie, our transfusion medicine consultant. You can contact the laboratory and they'll put you through to whoever if you've got any questions. And I would just like to say thank you for listening, and do you have any questions?
Okay. Does anyone have any questions for either of us? I'd be happy to take. Silence. Yes.
I was just asking about the thing with the hypercalcemia induced by the sodium citrate. So this is massive transfusion needs, using more than 4 units of red cells typically. Is it not worth just automatically giving them calcium? Lab results would just take too long for you to act.
Yeah, it's certainly something to consider. It's not part of the guidance that we've made, and certainly not part of sort of national guidance, but it's certainly suggested that it's something to keep an eye on. And it's usually it's just the plasma components that are the concern, really, rather than the red cells themselves. But yeah. Any other questions? Yeah.
Why do you have to make 2 protocols? Wouldn't it be better to throw 2222 and then just patch you through rather than finding a separate number?
It certainly would, but apparently it's impossible. Apparently. Having discussed it with the highest up people in switchboard, the 2222 line is apparently completely separate from the rest of the switchboard. And if they were to put a call through like that, nobody else would be able to phone 2222. So that's the reason. So yes, I agree that it's not perfect. But looking at other hospitals' policies, some of them are exactly the same. So I think it must be some quirk of NHS switchboards that's a problem. So yes, it's a shame. But hopefully it doesn't delay things too much, because the first call should really be a matter of seconds to say massive haemorrhage wherever, phone down and then phone blood bank. Yeah. I don't know.
No, that's not an voice over IP line.
Okay. Anyway. Okay. Any other questions? Yeah.
In another hospital I've worked in previously, one of the more useful bits of the major hemorrhage protocol was actually they sent you a porter that became your porter for this process. Is that to happen in this hospital also?
Yes. What's going to happen is the porter will, in the first instance, report to blood bank to take the initial components to the clinical area, and then will be involved in wherever they're needed. So whether that's in transferring a patient, samples, blood, yeah.
That's actually one of the reasons why we're required to do a 2222 call, because we have to contact the porters. If we were just to contact them, normally it can take up to 40 minutes for us to get a porter during the night to come. If it's a 2222, they report to the blood bank immediately. Yes.
Let's just check that has been agreed with it, that they are.
Yes, that has.
Issue for us in the labour space.
It has been agreed by. It's been agreed by management, and it's actually now been put into the contract that they are responsible for helping us to deliver blood components that wasn't in the contract before. Yes.
You talked to these people on point of care testing. Given that we can sometimes achieve a transfusion in under 30 minutes, you didn't really give me didn't come across an opinion. Do you have an opinion? Do you think it's something that we should have perhaps for the future?
A TEG or a ROTEM device? Yeah. I think at the moment, from what, I mean, I haven't got personal experience of using these machines at all. From what I've read, I think they're definitely worth investigating. But I think the amount of work involved in putting together the protocols and how to use them in these situations is going to be a huge amount of work. And knowing how to use the information that you're getting in your TEG trace or whatever, and how that then corresponds to what blood components you should be ordering, and then whether having that information does indeed improve the outcome for the patient, I suppose, is the thing. So.
I've had personal experience
Mm-hmm.
25 years ago, and you had an answer within 10 to 15 minutes, and the new ones put through to the transfusion lab, and they then adjusted their issuing of blood products according to that.
Yeah.
Whether it's improved patient outcome, who knows?
Yeah. I know it makes you feel better because you've got an answer sooner that you're acting upon, whether it influences things, I don't know.
One of the things that is, that I think surprises people who just how quickly people can read, but also how quickly you can replace that blood product, so that you're always, often with traditional lab testing, given that doctors get examined to the lab,
Yep.
blah, 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 you can often be lagging up to an hour.
Absolutely.
Behind, whereas something like the ROTEM or the TEG, you can reduce that lag time quite significantly.
Yeah.
Potentially.
Yeah. Yeah.
Must be a lot of data from liver units and cardiac units that could be looked at.
Yes, and cardiac surgery is the one area that's got good evidence to support the TEG and ROTEM's use for guiding your transfusion. Yeah. Any other questions? Okay, should we finish up at that then? Thank you very much. Thank you.